Hello and welcome back to this HIV third video module. In the video number 1, HIV video number 1, we discussed about the epidemiology of HIV, we discussed about diagnosis and the clinical features of HIV. In the video number 2, we went forward to look how the HIV attacks the human body, what is the basis of infection and the pathological basis of the pathological basis of the clinical features. And based on the pathological features, we discussed about the pharmacological agents that we have or the drugs which are used and approved by NACO in the update 2018. Lastly, in HIV2, we also discussed about ART, antiretroviral treatment, in all the special circumstances, pregnancy, in neonates, in people with hepatitis, tuberculosis, and so on. Now, I'm excited to present to you the video number 3 in which we are advancing forward into understanding the HIV disease. In video 3, we are going to discuss about pediatric HIV. We will discuss about treatment monitoring strategies. Third section would deal with the drug side effects, toxicities, and adverse effects of ARTs. Next, we will take up the prophylaxis for opportunistic infections, and lastly we will discuss about the post-exposure prophylaxis guidelines from the update 2018. So let's move forward in having a better understanding of this deadly disease HIV, and let's start with the pediatric HIV protocol. So let us start with our topic number 1. We'll talk of pediatric HIV guidelines. So if you talk about the pediatric HIV guidelines, please just a little bit information that if the mother is not having any ARV and the child is breastfeeding, do you know that the chances of transmission, the percentage chances of transmission in case of no ARV to the mother and the child is taking breastfeed, it is roughly around 25 to 45% of chances. But in case if the mother is taking, and in case if the child is not taking breastfeed, it is slightly lower, right? Because can HIV be transmitted through breast milk? Answer is yes. So do you know that in case the female is taking a triple drug ART regime, 3 ARVs the female is taking, and there is breastfeeding, now the chances drop down to from 25 to 45%. They drop down to simple 1 to 2%. 1% in case the child does not take breastfeeding, and 2% in case the child is taking breastfeed. So that means point 1, MCQ number 1, that breast milk can transmit HIV infection in tune of ranging from 25 to 45%. Next point, number 2. Please be advised that this can be an MCQ, that which of the following feed is the best type of feeding in a child born to HIV positive mother. Please remember that children who have taken exclusive breastfeed is much better than given simple replacement feed. So if the female is replacement feed, so if the female is giving exclusive breastfeed, it is better than giving replacement feed. And if the female is giving replacement feed, it is much better than giving a mixed feed. Mixed feed means mixing the breast milk with other top feeds. So if the female is able to do exclusive breastfeed, that is the best type of breastfeeding. Point number 3. How many times the feeding should be there? The feeding guidelines are roughly approximately 8 times feeding in 24 hours per day. There should be 8 times of feeding at least in children born to HIV positive mother, and exclusive breastfeed is the best type of feed. This we have already covered in the previous guideline from parent to child transmission guidelines. We discussed in section 2 of the HIV videos in the video number 2, where we talked of which is the drug of choice for prevention of parent to child transmission. The drug of choice, if you recall, it is nevirapine. So this topic we have already discussed. Just a quick recap that nevirapine is given to all children born to HIV positive mother for at least 6 weeks. For at least 6 weeks. And in case the mother did not take, if the mother in case the mother did not take no ART to the mother, or she received ART for less than 4 weeks. This means there is a insufficient amount of ART. So in those cases, the nevirapine should be increased for 12 weeks. Point number 3, so that was your first guideline. Second and third recommendation by the NACO is that in case the mother was previously exposed, if the female was previously exposed to nevirapine, now in those cases of archived resistance, we discussed about archived resistance in video number 2. Because of archived resistance, the drug of choice now becomes zidovudine. The drug of choice is zidovudine, and that was regarding the prevention of parent to child transmission guidelines. So please be remembered that in case this was a guideline number 4, that in case the child is exclusive breastfed, those cases the nevirapine prophylaxis may be extended to 12 weeks. But in case it is replacement feed, then the nevirapine is given for only 6 weeks, and the extension does not apply in all cases where the ART is given. So ART is given for a shorter time. So that means if a female was given ART for only 2 weeks, okay, and the female is giving replacement feed to the child, what is the prophylaxis we are giving to the child? I asked you a simple question, that if a female was given ART for less than 4 weeks and the baby is being given a replacement feed, no breast milk is given. So in those cases, the guidelines would say we need to give nevirapine only. We need to give nevirapine only for 6 weeks, right? So, but in case if the question says that the female is given ART for less than 4 weeks, and the child is taking exclusive breastfeed, what is the prophylaxis? We will give nevirapine for 12 weeks. So this extension of nevirapine applies only if the child is taking breastfeed. So in case the child is not taking breastfeed, then there is no extension of the nevirapine prophylaxis. Next, we come over to, in pediatric guidelines, we come over to ART regime in children. So again, now let us discuss the algorithm for giving ART to pediatric age group. So at the first level, we're going to confirm for HIV in children. How will you confirm for HIV in children? This is something known as early infant diagnosis. So please remember MCQ over here. What is the investigation of choice? Investigation of choice for early infant diagnosis. So investigation of choice, if it is less than 18 months child, the investigation of choice is HIV DNA estimation using real-time PCR. HIV DNA estimation using real-time PCR. And the investigation of choice in all people who are age more than 18 months, so more than 1.5 years, the investigation of choice is serological test or the antigen antibody test. So we will test for the NAT test, or we'll test for the ELISA test, all age group more than 1.5 years. Less than 1.5 years, this is known as early infant diagnosis using HIV DNA PCR. So we will check for the HIV infection. So we will check for HIV infection after confirming HIV infection either by the virological or by serological testing, depending upon the age of the child. You need to treat and stabilize any acute condition. In case the child is suffering from pneumonias, you stabilize the pneumonias. In case the child has malaria, you stabilize the malaria. In case the child has any hepatitis, you stabilize hepatitis. So any acute condition needs to be stabilized first before initiating ART. There is nothing known as that CD4 more than less than 500 or less than 350 we initiate ART. Please remember, current current treatment guidelines are start ART as soon as possible. So you get HIV, patient gets HIV, you start ART. It is known as treat all strategy. But to treat all strategy, you need to stabilize any acute condition. So once you stabilize any acute condition, now you will start the ART. Once the acute condition is stabilized, you start ART. How will you start ART? That is what the question of the day is. The starting of the ART is dependent on the age of the child. The age of the child can be less than 3 years, 3 to 10 years, or more than 10 years, right? So I told you that more than 10 years, it could be like we take it in under the adolescence, and we've already discussed the guidelines, but we shall have some overlap over here. You are just going to see. So either the child is less than 3 years or 3 to 10 years. If the child is less than 3 years, now you check for their anemia level. You check if their hemoglobin is less than 9 gram, less than 9 gram per deciliter, or it is more than 9 gram per deciliter. Okay, if it is less than 9 gram, if it is more than 9 gram, then the answer is very easy. If it is more than 9 gram, then you give to the child zidovudine plus lamivudine plus lopinavir with ritonavir booster. So this lopinavir ritonavir booster is the drug of choice for age group less than 3 years. So remember these words: age group less than 3 years, the recommended drug of choice as a part of the ART is lopinavir ritonavir. It should be given. In case the child is having anemia, then zidovudine is not recommended. So you replace zidovudine. You just replace zidovudine with AZT is replaced with abacavir. With abacavir plus 3TC plus lopinavir and ritonavir combination. So this is the guideline for age group less than 3 years. Now, if the child is age 3 to 10 years, now what is going to happen? If the child is age group 3 to 10 years, now you will see whether, again same issues, now you will see whether the child is more than 9 gram hemoglobin, or the child is less than 9 gram per deciliter hemoglobin. If it is more than 9 gram hemoglobin, now in age group 3 to before 3 years, the drug of choice is lopinavir ritonavir. In age group 3 to 10 years, mark my words, the drug of choice would be efavirenz. So lamivudine is always there. I told you lamivudine is one of the best drugs, one of the most safest drugs. Age group more than 3 years, it is advisable to give efavirenz. So we will give same answer. We will give zidovudine plus 3TC lamivudine plus efavirenz. So now the drug of choice is zidovudine, lamivudine and efavirenz. But in case the child has anemia, same issues, same thing comes again. In case the child has anemia, now you cannot give zidovudine. So AZT is replaced with abacavir plus lamivudine plus efavirenz. So just remember these words: in age group 3 years more, efavirenz; in age group 3 years less, drug of choice is lopinavir. In case of anemia, we will give abacavir. In case of no anemia, we will give zidovudine. So remember, in age group, just to summarize this game, age group less than 3 years, drug of choice is lopinavir and ritonavir. Age group more than 3 years till 10 years, drug of choice is efavirenz. In case of anemia, the drug of choice would be not, you replace zidovudine with abacavir. So that's what you have done till now. Okay. Now, in case we move to the last arm, that in case the child is age group more than 10 years. So obviously more than 10 years, it falls into the adolescent age group. So now it's interesting to see a good phenomena, not a phenomena, it's a good algorithm. In case if the child is more than 10 years, now you see simply the weight. Don't go with the hemoglobin. You see their weight. The weight of the child, not the baby, the body weight it could be less than 30 kgs or it could be more than 30 kgs. So the weight of the child could be less than 30 kgs or more than 30 kgs. If it is less than 30 kgs, so what? So if it is less than 30 kgs, it doesn't it look like a child who is less than 10 years of age? So of course, if it is less than 30 kgs, you simply go and shift to this guideline. So what was this guideline? So either it is less than 9 or it is more than 9. So that means you go and shift to this guideline. You see whether it is less anemia or whether it is less than 9 or it is more than 9. So in case the child is more than 30 kgs, so now this looks like an adult. So now you check for, you give them adult dose. That's what I'm going to say, that you give them adult dose. But before giving the adult dose, do you remember what was the standard ART? If you recall from the video number 2, we discussed many times that the standard ART is TLE, tenofovir, lamivudine, efavirenz. So before giving them tenofovir, don't you think we should check their kidney level? We should check their creatinine levels. So if you see creatinine can either be less or it can be more. Like in case you might have an abnormal creatinine or you might have a normal creatinine. In case the creatinine is abnormal, that means there is nephrotoxicity. In case of abnormal creatinine, again you cannot give the tenofovir. You again go towards the adolescent guideline, towards the other guideline, that is less than 10 years but more than 3 years, and if the HB is less than 9 or it is more than 9. So you cannot give tenofovir regime. But in case the creatinine is normal, that means the renal status is okay. So that if it is okay, we simply give TLE, that is tenofovir plus lamivudine plus efavirenz. So that is what we have as standard treatment regime for pediatric HIV. So this is what we have as standard treatment regime for pediatric HIV. So in pediatric HIV, less than 3 years, 3 to 10 years, more than 10 years, and you have all these drugs at your disposal for safeguarding the health of a child. Keep remembering, must remember that any child who is born to HIV positive mother, no stopping of breastfeed. Breastfeed is promoted. Exclusive breastfeed is much better than giving a replacement feed. And replacement feed is much better than giving a mixed feed. Next, what does the guideline have to say about the breastfeeding? Do you know that child is born, child exposed to HIV. So child is born to a HIV positive mother. To this child, we will give them nevirapine for 6 weeks. This we have already discussed many times. We'll give the child nevirapine for 6 weeks or nevirapine for 12 weeks or zidovudine for 6 weeks. We will give whatever the guidelines say. After 6 weeks, we will do the early infant diagnosis. This early infant diagnosis could either be positive, that is HIV positive, or it could be early infant diagnosis is HIV negative. If it is negative, we keep them on follow-ups. So there is a 6-monthly follow-up mechanism. But in case it is HIV positive, you start ART according to the regime just now told, less than 3 years, 3 to 10 years and more than 10 years. But now MCQ is, what do you do with the breastfeeding? So please remember, the breastfeeding guidelines are, in case of the child is diagnosed as HIV positive, the mother is recommended to do at least breastfeeding for at least 12 months, continue till 24 months. So we say for 2 years the breastfeeding should be continued in children who are diagnosed with HIV. And in children who are not like HIV negative, who are not infected as far as the clinical testing is concerned, in those cases it is recommended to at least continue till 12 months. That means the more, in case the child has HIV for 2 years, the NACO guidelines would be recommending breastfeeding to be done. At least in all children for 6 months, the breastfeeding should be there, and slowly the top feeds need to be added. It is said that if the mixed feeding is there in the early phases, it is said that mixing of milk somehow causes more chances of transmission of HIV infection, and that's the reason we have this. So that was regarding the feeding, and topic number 2 we have done is ART. Point number three in pediatric guidelines. Point number three in pediatric guidelines is that in case of all children born to HIV positive mother, all children born to HIV positive female, what do we do to them regarding vaccine? So I don't know, many times there are so many guidelines, so many people saying so many things, pediatrics faculty saying something else, PSM faculty saying something else, microbiology people saying something else. So everybody is doing like their own stuff, and NACO has its own guidelines. So what are the public health guidelines? The public health guidelines are all children born to HIV positive, they should get all the vaccines. Please mind the words, all vaccines as per schedule is given. As per schedule are given. So do not say live vaccines are contraindicated. Live vaccine, inactivated, killed, toxoid, every vaccine is given as per schedule. BCG is given, OPV is given, DPT is given. Only one vaccine is there, that DPT is to be replaced. DPT is to be replaced with DTaP. DTaP is diphtheria, tetanus, and acellular pertussis. Acellular pertussis. Why acellular pertussis? Because of the neurological complications of the pertussis vaccine. So whole cell vaccine of pertussis is replaced by acellular pertussis. So all vaccine is to be given as per the schedule. Only contraindication is that no live vaccine is given in case of CD4 count is less than 15% of expected, or if there is severe immunocompromised state, or the child is symptomatic with opportunistic infections. So if the child is symptomatic, opportunistic, severe immunocompromised, CD4 less than 15% of the expected, in those scenarios, of course, the live vaccines would be like troublesome to the child, and the live vaccines are not given. What are the added immunizations which are given? So added immunization can be remembered as HIPS, HIPZ. So these are the added extra vaccines. So which are the extra vaccines we give for HIV positive child? So in HIV positive child, we are going to give, H stands for hepatitis A vaccine, I stands for inactivated influenza vaccine. You can remember I for anything, either influenza or inactivated. P stands for pneumococcal vaccine, and Z stands for zoster, or we can say varicella. So you can remember it as varicella vaccine or zoster. For zoster, like we give this vaccine. So I'll just remember it as HIPS for HIV. So these are like your guidelines for pediatric ARTs or pediatric guidelines for HIV on how to diagnose, what treatment to give, what are the prophylaxis, and what are the vaccine and the feeding requirements. So now, after understanding the pediatric HIV guidelines, let's switch over to the next topic and discuss our section number 2. Let's talk about treatment monitoring and assessment of treatment failure, or initiation, when to start or when to switch over to the second line ART. Second line ART is not the scope of for the curriculum right now as far as PG entrance exams are concerned. So let's go with the next treatment monitoring, or how do we monitor. So if you look at the graph, if you see something like this, if I can make something like this, on this axis I have time. So HIV virus is a very consistent virus. It is going into the body, it is going to attack the CD4 cells, and the CD4 cells will die. So there is a consistent replication of the HIV virus. So this is the viral load. So usually in patients with viral load, if nothing, no treatment is done, or in case there is a treatment failure, there is a very consistent increase in the viral load, which is one of a very definitive signs that the treatment that you're giving is not working. If you talk about the immunological markers, if you talk about the serological markers, if you talk about the CD4 counts or the serological markers, they are something like this. So after a reasonable increase in the viral load, try understanding this graph, that after a reasonable increase somewhere at this point, after at this point increase in the viral load, now there is a start of decline in the CD4 counts. So I would, don't you think that CD4 count is a kind of a delayed marker for treatment failures? And if you see something else, that what happens to the clinical features or the opportunistic infections, they are something like this. They do not happen, opportunistic infections or the clinical features for HIV, they do not happen until and unless there is a considerable increase in viral load and a considerable decline in the CD4 count. So what I want you to understand is that if you are the treating physician for HIV cases, what do you want to keep a marker for yourself? Do you want to keep CD4 counts or clinical features or viral load? Of course, everybody would say viral load. Why? Because they are very sensitive marker. You catch them early. So even before the decline in CD4 count or the appearance of clinical features, you can still assess. So which of the following is the best marker for assessment of response? Assessment of response to treatment is best assessed using viral copies, viral load or viral copies, we can say. That is the best assessment response for viral load. So now if you understand this, now can you say that which of the following is the most sensitive marker? It is understanding, it is assessment of the viral load. So viral load assessment or viral copies assessment is the most sensitive marker. Once you assess the viral copies, they can be less than 1000 copies per ml, less than 1000 copies per ml, or the viral load can be more than 1000 copies per ml. If the viral copies is less than 1000 copies, so that means it's a kind of a controlled phenomena. Your treatment is acting, so nothing doing, patient is happy, you are happy, continue your ART. So that's a good response, that the viral load is less. But in case if the viral load is more, in case it is more than 1000 copies, that means there is some problem. So then what is the next step you do? You check for the adherence to ART. So in case of adherence to ART, what is the technical marker? We say that the patient should have more than 95% adherence in last or the previous 3 months. So in previous 3 months, if the 95% adherence is there or not there. If it is there, if it is not there, then of course you send it for counseling. If the adherence is not there, the patient was not taking ART, you send this patients for counseling sessions and you ensure that the adherence to ART is there. But in case the patient says that yes, I had been taking all the ARTs, now it is a matter of concern. So now you need to refer this patient to clinical expert panel. Every state in India has something known as state AIDS clinical expert panels, SACEPs. So you send them to clinical expert panel, which is going to assess and start the second line ART. Second line ART is beyond the scope of this PG entrance, but I'm just going to tell you a brief 3 points which is there in this whole chapter of second line ARTs. So let me just share with you what are the second line ARTs. So the second line, in case the patient does not respond to the first line ART. What is the first line ART? We've discussed it so many times. It is T, L, and E. It's a standard regime that we follow. Tenofovir, lamivudine, and efavirenz. So in case of treatment failures or virological failures or clinical failures, so you can start off with the second line ART. The principles of this second line ART is, what are the principles? There are 3 gross principles that you can remember. The first principle is we need to add a new drug. You add new drug in the TLE regime. 3-drug regime, you add a new drug. So what is the new drug that can be added? It is atazanavir, or boosted with ritonavir, or lopinavir boosted with ritonavir. So in short, I want to say that we add protease inhibitors. Remember, the second line drug is protease inhibitors, right? Second guiding principle. The second guiding principle is you need to add an unused NRTIs. Unused NRTIs, like you add zidovudine, or you add abacavir, or you add emtricitabine, or you add another drug, that is raltegravir. Raltegravir, if you recall from video module number 1, raltegravir is nothing but integrase inhibitors. These are integrase inhibitors, and I told you we do use them as second line, but the first line principal drugs are all the reverse transcriptase, NRTIs, NTRTIs, and NNRTIs. So add an unused NRTIs, add a new drug, and we always continue with lamivudine. So continue lamivudine, and the first two principles are the guiding principles for starting the next line of ARTs. What do you expect? So second line is raltegravir or zidovudine, or you use any unused NRTIs. What are the guiding principles? Point number 3. So under this new section of monitoring of HIV, first we talked of how the HIV can be assessed. The best is viral load. Second, we talked of the second line drugs. Third, what do you want to expect? What are the targets of your treatment? The targets of the treatment is to achieve a viral load of less than 1000 copies per ml, and it is to achieve a CD4 count of more than 350 cells per millimeter. So you need to have more than 350 cells and viral copies of less than 1000. That is the target the ART wants to achieve. So based on this, we can have 3 types of failures. That, if you understand the graph that we had seen before, if you see this, now there could be 3 types of failures based on which you can have the ARTs. Either we can have a viral load failure, which is the most sensitive answer, or we can have an immunological failure, where you will have decrease in CD4 counts, or there is a clinical failure. So if the immunological failure, when will you call as immunological failure? If the CD4 drops to less than 350. Clinical failure, any occurrence of new opportunistic infections in spite of treatment is clinical failure. Viral load is more than 1000 copies. So this is what types of failures we have, and these are the ART regimes, first line and the second line that we have. So next we come over to the third section. We will talk about section number 3. We will talk about the toxicities related to ART. So toxicities of ART drugs. Now let's talk about the next topic, that what are the various toxicities which can happen with ART drugs. So if you just look around the toxicities, you can see that all the ART drugs, they can be like NRTIs, or we can have NNRTIs, or we can have NTRTIs, right? We can have nucleosidase reverse transcriptase or non-nucleosidase. If you talk about NRTIs, like we have 3TC, we have zidovudine, you have abacavir, all these things, they predominantly cause most of the mitochondrial damage, and they cause mitochondrial toxicities, which further can lead to various toxicities, which can lead to various various conditions like lactic acidosis, pancreatitis, myopathies, peripheral neuropathies, and very important, you had already discussed, is anemia. So these are like your most often things about the NRTIs. Mostly they will lead to mitochondrial toxicities. If you talk about the NNRTIs, the NNRTIs, non-nucleoside reverse transcriptase inhibitors, that is the efavirenz and nevirapine, they will be predominantly causing skin problems, skin rash. Then we have hepatitis and some CNS like involvement. Hepatitis, if you talk of, hepatitis is most predominant with nevirapine. Nevirapine is known to be associated with hepatitis and with skin rash. If you talk of nevirapine, we always have 6 monthly to 1 year checkup follow up for liver status. So hepatitis and skin rash is for nevirapine. Nevirapine, do you know, lateral MCQ? It's also responsible for something known as Steven Johnson syndrome. So SJS syndrome, hepatitis, skin rash is for nevirapine. So if we talk about the CNS involvement has typical MCQ which can be linked. That CNS involvement is can be seen as part of the efavirenz adverse effect. Efavirenz, people who are put on efavirenz, they have this peculiar CNS involvement, that is dizziness, confusion, and they will also have insomnia. So a lot of dizziness and insomnia with confusion, and they have a peculiar fancy term that we use. They have vivid dreams, a lot of colorful dreams. Their brain activity is enhanced in terms of vivid dreams will be there with efavirenz. So that is for efavirenz. But nevertheless, efavirenz can also have liver toxicity. Nevirapine is Nevirapine is known for hepatitis, Steven-Johnson syndrome, and skin rashes. On the other hand, if you talk about the nucleotide reverse transcriptase inhibitors, that is the tenofovir. So if you talk about the tenofovir is for nephrotoxicity, and for bone marrow suppression, and very important for TDF is we have this bone mineral density is reduced. So nephrotoxicity along with the maybe pancreatic toxicity, but more so for TDF. Please remember, these patients are prone to develop nephrotoxicity and they are prone to develop bone mineral density, and that is the reason people who are put on TDF, they are also put on calcium supplements. Calcium supplements are advised along with TDF, and their renal function is monitored. So that's like two things you can remember for tenofovir. And nevirapine is this. A few important points about lopinavir, because it is given, if you recall from just now, we had discussed about lopinavir and ritonavir. So lopinavir-ritonavir combination, it is given, if you recall, we had just done this, age group was less than 3 years. Less than 3 years, we were giving lopinavir-ritonavir combination. So in those children, they are prone to develop diarrhea, GI upset, and bowel disturbances. Plus, lopinavir can also cause liver failures, and glucose intolerance. Lopinavir is also not in people, and sometimes lopinavir, if you recall, we also did it as a second line treatment for adults. So lopinavir for adults, if you are giving, it is not given with a drug, that is simvastatin, because it has a drug interaction with simvastatin, that it increases the level of simvastatin, and the simvastatin causes a lot of rhabdomyolysis, and that is the reason, in case you're combining lopinavir ritonavir with simvastatin, now this patient will have much enhanced exaggerated rhabdomyolysis, which further may lead to nephropathies, or may lead to renal failures due to rhabdomyolysis. So lopinavir has important drug interaction with the simvastatin, right? So this thing, 3-TC lamivudine. Lamivudine does not have too much of toxicities. It is one of the most safest drug. The only toxicities we see with the 3-TC, the only toxicity, mostly 3-TC is like a very harmless type of drug, but it can cause abdominal discomforts or cramps, but it is a safe drug and very potent drug. Next is, if you talk about the ART drugs, when we give ART drugs to patients with HIV, there is sometimes something related to toxicities I'm going to talk. There is sometimes development of IRIS. What is IRIS? Immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome, that means like the immune status is reconstituted. It is nothing but IRIS is symptoms. It's a congregation, it's a condition where the patient is put on ART and they start showing clinical signs and symptoms from the infections already present in the body. Mind you that HIV, this patient's body host defenses are gone. So his CD4 count, his or her CD4 count is gone. So this patient can not produce any immunological response. Once you treat this patient, this immune system of the patient starts growing up. And once the immune system grows up, any infection which might have been hidden in the body now shows up. This phenomena is known as immune reconstitution inflammatory syndrome. So what is IRIS? It is nothing but an exaggerated immune reaction towards previously present infections which were hidden inside. So this type of immune reconstitution inflammatory syndrome can happen anytime from 2 weeks till 12 weeks. Usually, the usual time is 6 weeks, and in some cases it may extend till 6 months. Why I'm telling you the time is that many times we start patients on ART, so now it is very confusing for the physician to judge whether it is a new infection or was it an infection which was latent inside the body and it's just now showing up because the immune status of the patient is increased. So IRIS is a thing which we are all scared of, because you really cannot understand whether it's a new infection, whether it's a treatment failure, or is it a treatment response. And you need to treat the condition after all. So it becomes a very tricky phase for a physician. So IRIS can be classified into 4 types. IRIS can be of unmasking type, unmasking IRIS, or we can have paradoxical IRIS, host IRIS, or we can have a malignancy IRIS. So unmasking type is already present infection which was running, but because the person's host immune status was not there, so therefore this patient was not presenting. So it is previously present latent infections. So most of the times you're scared of like IRIS, you don't know whether it is new TB or old TB. That tuberculosis and cryptosporidiosis, these are 2 infections which are very often of troublesome for the physician who are tackling HIV cases. Paradoxical is because of the dead or treated organism. Sometimes the treatment for a condition is already done, the organisms are there in the body which have been treated, but because this immune status now is increased, so now they start seeing this organism as foreign and they start reacting to it. So it is because of the presence of the dead or the treated organisms inside the body. That's a paradoxical IRIS. Host IRIS is nothing but a simple immune reaction, and malignancy is for cancers, right? So these are like 4 types of IRIS. And what are the risk factors for IRIS? What are the factors like which you should be knowing, that in which patients should we expect an IRIS? In patients who have very profound immunodeficiency, who have too much profound immunosuppression, we will expect IRIS. Because once you're giving ART, this viral load has to decrease and the CD4s have to increase. So if there was too much low, now there is something better. So this is one biggest risk factor. Second is immunosuppression is CD4 count usually less than 100. It's a problem. So before starting ART. So now, and also if you give intense ART and there is a rapid decline in viral load, so that is also one of the major risk factors. Or you might have untreated or partially treated infections prior to starting ART. Is all our risk factors for IRIS. So that was regarding the IRIS, immune reconstitution syndrome, and how do we treat them? The treatment is absolutely same. You have to treat the infection and the ART has to concomitantly go on. So that completes your section number 2. Now we come to the section number 3 for HIV, and the last topic is post-exposure prophylaxis. So as we move forward in understanding HIV, let's come to one of the very important topics and one of the most high yield topics, that is post-exposure prophylaxis for HIV. So this area is like one of the favorite questions for examiners, and they will ask many times these questions like what are the regimes, what are the protocols. So NACO has also updated 2018 guidelines for the post-exposure prophylaxis. So if you talk about question number 1, post-exposure prophylaxis, you need to know that in case of blood transfusion, the mode of HIV infection via blood transfusion, it is roughly 90 to 95. In case of perinatal transmission, we have already talked 15 to 40% chances, whereas in case of sexual or anal intercourse, it is roughly around 0.1. It is roughly 0.1 to 10% depending on the route for sexual intercourse. So also I would like to inform that in case of needle stick injury, the chances of getting HIV infection is fairly less, 0.3%. So needle stick, people think that it's very highly infective, but needle stick is 0.3%. And do you know, a lateral MCQ, that if you talk about the needle stick injuries, the chances of developing hepatitis B infection is the maximum from 10 to 30%. And if you talk about needle stick injury and chances for hepatitis C virus, it is again 1 to 2%. Right? So that the chances of developing HIV via blood transfusion is maximum, and sexual intercourse or needle sticks is fairly less. So anytime if a person gets infection due to some blood or OPIM, other products which are infectious material, right? So blood or other products which are infectious material, so in those cases we need to give them some post-exposure prophylaxis. So let us discuss the post-exposure prophylaxis guidelines by NACO. In case a person gets exposed to blood or other products which are infectious, so in this we see something known as exposure codes. These are something new probably for you, so there is a good chance that the examiners might ask you. So we see for the exposure codes, we see that how much amount or the severity of exposure. So if you talk about the severity of exposure, you talk about the type of exposure. If the type of exposure is on skin or mucous membrane, or it is on broken skin also, but there is no penetration, non-penetrating injury. In those cases, we will assess whether it is short duration or it is a long duration. If it is a short duration, or it is like very small blood, small amount, small quantity, or for short duration or large quantity, or which is long duration, then this is known as the short duration. This is known as the exposure code number 1. This will be labeled as exposure code number 2. So there are two exposure codes in case it is a mucous membrane, blood spilling on the skin, blood spilling on the mucous membrane or anywhere. It is like exposure code 1 or 2. But in case if there is a penetrating injury, second is in case of penetrating injury. In case of penetrating injury or a percutaneous exposure, so that means something went inside the skin. So once something goes inside the skin, now that is like slightly more dangerous. So we have two options again. So this penetrating injury can either be with a solid needle, or it could be less severe, or it could be with a hollow needle, or it could be more severe, right? Hollow needle or severe, and solid needle or less severe. So in case it is a solid needle or a less severe, this is given again as exposure code number 2. Whereas if it is a hollow needle, that is a severe penetrating injury, it will be graded as exposure code number 3. So in short, what I have discussed with you right now is there are 3 exposure code: mild, moderate or severe. Mild is if there is short duration, moderate is either large amount of blood on the mucous membrane for longer duration, or small amount of penetrating injury. That is moderate. So this is somewhat as mild. This is, you can label it as moderate. This is, you can label it as severe. Mind you, in your exams, you need to remember the exposure codes. Examiner probably can ask you mild or moderate or severe, but I think you all are intelligent enough to understand, because they won't be giving you direct easy questions, right? So that is about the exposure code. Second, under the NACO 2018 guidelines, they formulated a complex algorithm which is containing the exposure code, severity, and it also asks about the details of the source code. So now there is a second thing that you need to remember about the source codes. What is the source code? It means that it is regarding the patient, regarding the person whose blood comes and whose blood is exposed. So source code, the source could either be definitely HIV negative, or it could be definitely HIV positive, or it could be unknown source. Am I right? These are the 3 things which can happen. If it is HIV negative, please remember, if it is confirmed HIV negative, then there is no PEP requirement. This is out of boundary. So in case you know that the patient is non-HIV, then there is no point in thinking of HIV post-exposure guidelines. In case the patient is HIV positive, now you will assess the severity of the source. If the source is having low CD4, that is less than 100, if the patient is having, maybe let's first talk of high CD4. If the patient is having average CD4, CD4 is high, or the patient is asymptomatic, that is known as source code number 1. That is source code number 1. CD4 is high, patient is asymptomatic. But if the patient is having low CD4, less than 100 cells per millimeter cube, or if the patient is symptomatic for HIV, even he may be on treatment or may not be, this is labeled as source code number 2. And unknown is labeled as direct source code unknown. Okay, so now there are three types of exposure codes and two types of source codes that you can see on your screen. So these three types of these three types of exposure codes and two types of source codes, or three types of source code. So now we will make an algorithm from this. The algorithm that we will make from this is that in case we will talk of the exposure code first. Exposure code, as you can see, could be exposure code 1, exposure code number 2, or exposure code number 3. So if it is exposure code number 1 and then you see the source code, the source code could be like 1 or it could be 2. Leave aside the unknown. If the source code is either 1 or it is unknown. So now if it is 1, please remember, if there is a mild exposure even with the patient from HIV who has a reasonably okay CD4 titers, in those cases no PEP is recommended. In case it is mild but the patient is HIV positive and the CD4 counts are low, we have to send this patient for post exposure prophylaxis. Exposure code number 2. Exposure code, if you recall, that either large amount of blood on the skin or small penetrating wounds. Exposure number 2, either it is source code 1 or it is source code 2. Anything, either source code 1 or source code 2, we send it for post exposure prophylaxis. And if it is exposure code number 3, if you recall, that's a hollow needle, that again obviously either it could be 1 or it could be 2 or it could be unknown source. Anything, we send it to post exposure prophylaxis. So only thing that you need to remember is you will not give post exposure prophylaxis to patients who are mild exposed even if the source was HIV positive. So this is about the source codes. So if you understand the guidelines now, if you understand that you are going to give a PEP to which patients, now let us see what is the PEP. So first thing that you have done is who are the patients who will receive PEP. Second, what is the PEP you will give. So section 2 or point number 2, let's come and learn about the PEP regime. What is the PEP regimes that we offer? So the NACO 2018 has updated the PEP standard regime as tenofovir plus lamivudine. That's all, 2 drug. So earlier it was 2 drug regime or 1 drug or 3 drug. Now there is nothing known as 1, 2, 3. We have standard regime of 2 drug regime. Tenofovir or lamivudine. So tenofovir is given at the rate of 300 milligram, lamivudine again at the rate of 300 milligram. This is given for OD, 1 tablet, OD dose. It is to be given for 28 days or 4 weeks. Please remember one more MCQ, lateral MCQ. The PEP in a patient has to be started within 2 hours. You started within 2 hours. You start PEP within 2 hours, and maximum it should be within 72 hours. So within 72 hours we have to try all the PEPs to be started, but preferably within 2 hours. In case the TDF and 3TC is not available, there is a second line, or in some patients the TDF tenofovir is not recommended. In those cases we need to give them second line post exposure lopinavir and ritonavir combination. Lopinavir given at the rate of 200 milligram and ritonavir given at the rate of 50 milligram. These are given as 2 tablets BD dose, again for 28 days or 4 weeks. So in cases where tenofovir is contraindicated, you can go along with lopinavir or ritonavir combinations. In cases of children with sexual abuse, the standard regime for post-exposure is zidovudine plus lamivudine plus lopinavir and ritonavir combination for children. So that's the standard regime that we have for adults and for children in case of post-exposure prophylaxis. That's all for the post-exposure prophylaxis for HIV. I would also like to share, I would like to take this opportunity that because since we are discussing over here, many times a lot of questions come to us on social media about the hepatitis B vaccination protocol. So please remember the NACO has integrated with the hepatology guidelines as well for hepatitis. So hepatitis B vaccine in any acute exposure, I'm discussing about the hepatitis B vaccine, in any acute exposure to blood. Most of us are like, obviously all of us are healthcare professionals, so many times we get exposed to blood. So acute exposure to blood, you simply see that whether you are vaccinated or not. So in the case the person is never vaccinated, the guidelines are very simple: directly go for 3 vaccination, take full complete HBV vaccine schedule. So you directly go for HBV complete vaccination schedule. In case you have been vaccinated, in case you are vaccinated, now you need to see whether you were vaccinated less than 5 years or more than 5 years. If you have been vaccinated for more than 5 years, if your vaccine was 5 years before, now directly you need to do nothing but take HBV booster vaccine, single shot of HBV vaccine. In case it is less than 5 years, in case it is less than 5 years, now you see the antibody level, you see the anti-HBs antibody. You see the anti-HBs antibody, and if it is less than 10 milli international units per ml, or it is more than 10. If it is more than 10, then nothing to be done. But if it is less than 10, again we need hepatitis B booster vaccine. So that was regarding the vaccine schedule for HBV, hepatitis B vaccine. And many times students have also asked me that, sir, we have taken hepatitis B 1 and 2 and we did not take hepatitis 3. So what to do? It's been 5-7 years. So please remember, the standard protocol for hepatitis B vaccine is always to resume, never to restart. So if you have taken vaccine 1, you have not taken 2 and 3, you do with 2 and 3. If you have taken 1 and 2, you have not taken 3, no problem, you take the third one. So nothing to restart, only is resume lifelong. So with that, we complete all the questions which can be asked on 2018 update NACO for post-exposure prophylaxis in HIV. Continuing with HIV update NACO 2018, let me come over to an important chapter, that is prevention of opportunistic infections in people living with HIV. So obviously you all understand that people who are living with HIV, they need to be put on treatment, that is ART. And right now we have a treat all strategy. So once this patient all are put on treat all strategy, the CD4 count is well nicely more than 500, 600, 700 also. So but there are chances of getting opportunistic infections, and I think you all understand that people living with HIV who might not have started treatment, or there is no confirmed adherence to the treatment, they might land up into opportunistic infections. So MCQ, first number, which is the most common opportunistic infection? The commonest opportunistic infection in PLHIVs is tuberculosis, followed by, we are scared of cryptococcal infections, followed by cryptosporidiosis, followed by we can have CMV infections, followed by we are also scared of hepatitis, and of course pneumocystis carinii or Gerovesi infections. So these are most of the opportunistic infections which can have a fatal manifestation in PLHIV. So we need some guidelines to take care of these infections. So let me talk of the guidelines under NACO 2018 update. So first is regarding CPT prophylaxis. CPT is cotrimoxazole preventive therapy. So the basic understanding in HIV you need to take is there are two types of prophylaxis. We'll give primary prophylaxis and we'll give secondary prophylaxis. What do you mean by secondary prophylaxis? Primary prophylaxis is you give the treatment, you give the therapy before the start of disease. Secondary prophylaxis is after the disease has happened. We give some drugs to prevent the future attack of the disease, or to prevent any rebound of the disease, because there are many times reconstitution syndromes which are associated, immune reconstitution syndromes, which can land up into problematic areas. So this is cotrimoxazole preventive therapy. It is primarily given in TB patients with HIV or only HIV at a certain CD4 count. So let's just discuss cotrimoxazole preventive therapy, CPT. What are the MCQs you need to remember for CPT? I hope you all know what is cotrimoxazole. It is a mixture of trimethoprim and sulfamethoxazole, TMP-SMX, trimethoprim and sulfamethoxazole, right? So cotrimoxazole preventive therapy, when do you start? You start CPT prophylaxis when the CD4 count is less than 350 cells per millimeter cube, or if the patient is HIV stage 3 or stage 4. So if the patient is HIV stage 3 or stage 4, or if the CD4 count is below 350, you start CPT. When would you stop CPT? So obviously when things you start, you have to stop. So when would you stop CPT? We will stop CPT when the CD4 count is more than 350 cells per millimeter cube on two occasions, 6 months apart. So on 6 months apart, you need to check for the CD4 counts, right? So this is regarding the CPT prophylaxis. How much amount of, what is the dose of CPT? We will give TMP and SMX, right? TMP is given at the rate of 160 milligrams and sulfamethoxazole is given at the rate of 800 milligrams, and this is given daily. This is given daily for the time that CD4 count is not okay. So in CPT, you have something known as primary CPT prophylaxis, or we can have secondary. What is primary? It is given to prevent the first attack. So it is given before disease. It is given as per, not before the disease, it is given as per the CD4 counts, right? It is given on the basis of CD4 count. What is secondary? It is given after treatment, after complete treatment of pneumocystis carinii pneumonia. So in case of full complete treatment, we now give this PCP, and this PCP should be given for 21 days for 3 weeks. So there is primary or secondary. Primary is based on the CD4 count, secondary is based on the time duration. Secondary, you give it for 3 weeks. In some people who are TMP SMX sensitive, like SMX is sulfamethoxazole, so obviously I hope everybody understands it's a sulfur containing drug. So in case of people who are having sulfur drug sensitivity, you need to, in case of sulfur drug sensitivity, what we do, the guidelines say we need to desensitize the individual. But in some cases where you cannot even desensitize the individual, the second line of drug for PCP prophylaxis is dapsone. So dapsone is given for the same duration at the rate of 100 milligram tablet is given for the same duration. So that was regarding the CPT prophylaxis. What did we do? CPT prophylaxis can be primary, can be secondary. Primary based on CD4 count, secondary can be based on the time duration. You start at 350, you stop when it is more than 350, or if the patient is not HIV stage 3 or stage 4. Second information about the prophylaxis you need to do is regarding the isoniazid prophylactic therapy, IP and T. Isoniazid prophylactic therapy. So isoniazid prophylactic therapy you give to whom? Of course, I told you there is something known as intensified case finding. If you recall, when we discussed about ART in special situations, I told you that all people living with HIV, we will do intensified case finding for tuberculosis, right? I told you we had discussed this, that we will do intensified case finding based on what? We'll screen everybody for TB. So we screen everybody for TB, and in case we find them yes TB, based on cough, fever, nitrates and all that, we start, if they find yes TB, we check them for sputum, and for CB nats we will start ART. But in case there is no TB indication, in case there is no TB, you give them IPT prophylaxis. This IPT, isoniazid prophylactic therapy, is given to all people who are living with HIV, who have been diagnosed HIV recently. This IPT prophylaxis is given for 6 months. Isoniazid preventive therapy is given for 6 months, in which we will give isoniazid at the rate of 300 milligrams along with pyridoxine. It is given at the rate of 50 milligram, and this is continued for 6 months. Please remember, IPT prophylaxis is contraindicated. You should also know IPT is contraindicated in any active form of TB, any type of TB. It could be normal TB, reactivation TB, or it could be MDR TB, or it could be XDR TB, any type of TB. It is also contraindicated in MDR TB contacts. It is also contraindicated in active hepatitis, or in cases of peripheral patients who already have peripheral neuropathy. So please remember, IPT prophylaxis, we give it for how much time? MCQ1, we give it for 6 months. IPT is contraindicated in MDR contacts. It is contraindicated in any patient with MDR, with TB, and in, of course, in hepatitis also. IPT, you give it for 6 months. Alongside IPT, you have isoniazid and pyridoxine. The third chemoprophylactic agent that you need to study is cryptococcal meningitis. So in cases of cryptococcal meningitis, please remember, there is nothing known as primary cryptococcal meningitis prophylaxis. You cannot, there is no role, like it is only given as, what we use for cryptococcal meningitis is only secondary prophylactic therapy. I hope you understand. It is clear now what is primary, what is secondary. Primary is before the disease, secondary is after the disease, treatment of disease. Then you give prophylactic again. Why? Because to prevent other forms of disease or severe forms or reactivation or reconstitution syndromes, you want to complete the therapy. So the secondary prophylactic therapy for cryptococcal meningitis is given after treatment of cryptococcal infection. The drug of choice is fluconazole. Given at the rate of 200 milligram per day, given at least for 2 weeks. So this is for cryptococcal meningitis and IPT and cotrimoxazole preventive therapy. And these are the important opportunistic infection prophylaxis that we take care in tuberculosis and HIV. Well, that's all for HIV, and I thank you so much for watching these videos, and I wish that we would have done many other infections in the same manner, using the integrated approach towards treatment of disease. I am a firm believer that this is a science, this is a medical science which evolves as we understand the disease, and the understanding is not limited to particularly one subject. Understanding is when you have a holistic approach towards the disease. So with that, covering almost every nick and corner about HIV, I thank you so much for watching these videos. I wish you all the very best, and you have these Facebook forums, you have the Telegram forums and the WhatsApp groups at your disposal. Wherever there is doubt, you are always welcome, and you are encouraged to put your doubts on the forum, and we'll be happy to answer them. I wish you all the very best in your upcoming exams. May God bless you. Thank you so much.